you for asking me. Now, am I broadcasting overhead here so can you hear me when I talk in a voice like this? Okay. Today we're going to be talking about drug eruptions, diagnosis, management, significance of drug eruption as you manage your patients. I'm Dirk Elston. I'm from BAMC, and we have a mixed population of patients there, including a large number of retirees. San Antonio is a big retirement town, and we see more than our share of older patients. When I prepare for these lectures, I always try to dig through my material and bring you some of my best slides. So the first slide I have to show you is me digging through my material to try to show you some of my best slides. So I hope you enjoy what I have for you. Would we be able to put these lights down a little bit? I think they project better. Oh, do I have the controls here? How do we?
Have some there. You might try it up there, see if you're better off.
Let's see. Well, not that one. Just switches. Let's see. That's maybe too much. Let's see here.
How about just putting one?
Well, I guess one. We don't seem to be able to do front versus back. Has someone done that before? No? Out? Is it? Okay. Let's see. Okay. I think it's better to see the slides than to see me. Drug eruptions are far more common in older patients than in younger patients. The reason is very straightforward. Older patients are exposed to far more drugs. Studies of the effect of the drug in skin of an older individual versus younger, there are certain effects, atrophy, some others that older skin is more sensitive to. But by and large, older skin reacts very much like the skin of the infant in regard to a given drug, but the incidence of exposure is so much greater that we see drug eruptions with far greater frequency in older patients. When evaluating one, the first question is to look at the history. What drugs have been applied, or what drugs have been taken internally, and when? What was the time course? The pattern of application, the time course, will help identify which drug. And that's always the big question that we're asked. When we're called to the ward, the clinicians already know it's a drug eruption. That's not the big mystery. The big mystery is which drug. Mr. Smith is on 25 drugs. We can ill afford to take him off most of those, but we obviously have to take him off one. Which is it? And that's where we can contribute most of the time. What I'm going to try to help you with is, one, management, but diagnosis is very important here because the big question is which drug. And an organized approach will help you with that. In this particular case, this gentleman had surgery for skin cancers, squamous cell carcinomas on the hand, has this persistent eruption. This is now a month and a half after his surgery, and he has a weeping, intensely pruritic eruption on the hands. The question, of course, is what has he been applying? In this case, it's very simple. It's bacitracin in this case. Neomycin is a far more common culprit, but many of the topical antibiotics can give a contact dermatitis. Diagnosis is important because of cross-sensitization. There is cross-sensitization between neomycin and gentamicin aminoglycosides. Can be seen. It's not 100%, but once you've been sensitized to neomycin, you are more likely to have a systemic reaction to an aminoglycoside drug, which are drugs very commonly used for gram-negative, especially hospital-acquired infections. We therefore, when we do cutaneous surgery, we use drugs like bacitracin that if the patient becomes allergic, they don't have the same significance as far as cross-reactions with other drugs to which they'll be exposed. And we encourage the use of drugs with less cross-sensitivity to be used as topical antibiotics. As far as management here, a topical steroid. 0.1% triamcinolone cream is relatively cheap. The generics are available. It comes from 15-gram tubes, which would be adequate for this, to large bulk dispensing. The pharmacy will often get in 5-pound jars. They look like industrial-sized mayonnaise jars full of triamcinolone cream, and that can be put into whatever size container you need. Triamcinolone is cost-effective. It's a fluorinated steroid, which means that it has a lot of power to it. It has a lot of oomph. And yet it has a very low incidence of sensitization to the steroid itself. One of the problems that's being increasingly recognized, especially in older patients, is contact allergy to the steroids that the patients are applying to treat contact allergy, so that the medication itself becomes a problem. Of all the steroids that are applied, the least likely to induce contact allergy is triamcinolone. Triamcinolone is also available in a pure ointment base. So just white petrolatum, which is Vaseline petroleum jelly, with triamcinolone. There's no fragrance, no preservative, very bland, soothing emollient formulation that can be used. And for short-term application, treatment of contact dermatitis is probably the drug you would use most often. On very delicate skin, such as the skin of the face, or for prolonged use, it is not appropriate because it's too strong. There are milder agents, hydrocortisone, tridecylan, which is decinide, that are more appropriate, especially on the eyelids. Decinide ointment, brand name tridecylan ointment, is pure steroid and petrolatum. So if it gets in the eye, and especially older patients often have trouble when they apply, they can't keep it just on the lid. If some gets in the eye of tridecylan ointment, it's not going to do any harm. This is your basic Morbilliform drug rash. Morbilliform meaning measles-like. This is the only true maculopapular rash. Rashes, macules are flat, papules are raised and rounded. These are essentially flat, but just have just a little bit of induration to them. If you run your fingers across, they are just a little bit raised compared to the surrounding skin. And this is what the rash of measles looks like and what your most common drug rashes look like. Morbilliform rashes, there is nothing about the appearance of rash that will point you to the drug, but the time course will point you to the drug. The drugs that were started yesterday, the day before that, are not the ones implicated. They're the ones that the clinicians are usually most concerned about. You know, we started the person, Mr. Smith, on an antibiotic 3 days ago, now he has a rash. It's probably not that drug. It's probably the antibiotic he was on before that, 1 to 2 weeks ago. The time course with a first exposure to a drug, the average time for morbilliform eruption to occur is about 2 weeks after the first time the patient's exposed to the drug. Most drugs, especially antibiotics, which have a high incidence of drug rash, are given for a 10-day period. So it works out about 4 days after they're off the antibiotic is when the rash will occur. When we see the patient, they've often been taken off their hypertension medications, they've been taken off of half the things they're on, and the culprit is long gone because the culprit was stopped 4 days ago. It's important to know which the culprit was for future use because many of these drugs do cross-react, and to eliminate drugs that the patient's on. But that time course, first exposure to a new drug to the time the eruption occurs, the range is 5 to about 25 days, but the peak, most of them, somewhere about 2 weeks, or a 1 to 2 week interval, is where you'll see most of the morbilliform eruptions. Now, the second time the patient's exposed to the drug, the eruption occurs much more quickly. Can occur within hours, but more likely 48 hours. Urticaria is the one exception to this. Urticaria, or hives, true hives, do occur much more quickly with exposure. But for your most common pattern of drug eruption, which is the measles-like morbilliform eruption, the usual time course after first exposure is 1 to 2 weeks, or for antibiotics, most frequently for a short course of antibiotic, standard 10-day course, about 4 days after the antibiotic has stopped. The pattern of the eruption is often helpful as far as diagnosis. The skin has many structures to it. Within the skin, there are hair follicles, sweat glands, blood vessels. Certain drugs will affect certain of these structures. That will give you a different clinical appearance in the skin and will point you often right to the drug. We're going to go through some patterns of eruptions. This patient is having chronic ambulatory peritoneal dialysis and has an eruption around the catheter site that not only is distressing to the patient, but is heavily colonized with Staphylococcus aureus. Makes him a risk to other patients on the ward, definitely sets him up for a peritonitis, which is one of the big problems with COPD. What you need, because of the pattern, this is a discrete pattern, you need to know what he's been applying. In this case, it was simply betadine that the patient was allergic to. We can do patch testing, we can do allergy testing, and we can give you an answer. What the patient's allergic to, what substitutes are available, what drugs will cross-react, what drugs will not cross-react, what systemic drugs cross-reactions can be predicted because of the reaction the patient's already had. As far as treating this given episode, this is not on the face. This is on the abdomen, so triamcinolone ointment, preferably in white petrolatum, would be excellent choice. Give rapid relief within 24 to 48 hours. This patient has a photo eruption, has prominent involvement on the cheeks, prominent involvement on the forehead, definite sparing under the brow, definite sparing under the philtrum of the nose. A photo eruption points you to the drug. There are certain drugs that classically give photo eruptions. Sulfa, tetracycline, thiazide, chlorpromazine, or the whole group of phenothiazines, the sulfonylureas, the oral diabetic agents, all of those photo eruption drugs. So if it's a photo eruption, you've already been able to narrow from a long list of the medications the patient may be on. You can narrow the list to the one, maybe two drugs the patient is on that are the culprit. Elimination of those drugs, is that better for those in the back? Okay.
Right, they're all going to go on.
Okay, thank you. Elimination of those drugs cures the rash, and the diagnosis is made easy by the pattern of the eruption, the fact that it's a photo eruption. This person also has a photo eruption, in this case to a thiazide diuretic. It's very easy to identify because where the watch band was on the arm, totally spared, no eruption. So those clues as to distribution can give you the diagnosis, which agent was responsible. This is a papular photoeruption. Papular photoeruption is fairly specific. This is feldene, piroxicam. Feldene gives only in areas of sun exposure a very papular or papulovesicular, meaning little red bumps and little fluid-filled blisters. Frequently happens when the patient has been on feldene for months. So this is not like your measles-like morbilliform eruption where it's normally 2 weeks after the drug is started. This happens, this patient has been on feldene for months and months, when this eruption occurs. But by the pattern of the eruption, you can look at it and you know that's Feldine. That's a Feldine rash. All of these are Feldine rashes. And this papulovesicular rash, also Feldine. And this one as well. The drug is delivered to the skin in part by the sweat duct apparatus, and many of these blisters are around the pore where the drug is delivered to the skin by the sweat. And we can do photo patch testing. This is Feldine applied to the skin. It's kept occluded, meaning that something is put over it for 48 hours. And then ultraviolet A light is irradiated onto the skin, and you'll get the same eruption. And that proves that it's a Feldine eruption. And in cases where there's any question as to the diagnosis, we have the diagnostic tests available where we can show you which drug it was. This eruption is centered around the hair follicles. Everywhere where a little hair comes out, the eruption's centered around the follicle. And this as well, you can see where every little hair protrudes, there's a little red papule. This is another drug where the eruption typically happens after months on the drug. So the time course doesn't help you, but the pattern helps you. This is phenytoin or dilantin. Dilantin for seizures will give you a distinctly follicular, centered around the hair follicle rash. So the pattern of the eruption tells you what drug. The treatment is withdrawal of the drug. In this case, essential to withdraw the drug because this is a marker for severe reactions that will develop to dilantin, including massive necrosis of the liver, lymphoma-like reactions that can progress to true lymphoma. And all of these, the marker is the cutaneous rash. Rule of thumb, a patient who is on any seizure drug who develops a rash, it's a medical emergency to determine if it's related to the seizure drug. Because all of the anti-seizure drugs, Tegretol, Dilantin, have a very high incidence. If they are causing a rash, they are also damaging the liver. And misdiagnosis or delay in diagnosis can lead to hepatic necrosis of the liver, which is not a good thing. This is what we call a livido pattern. A livido pattern is a net-like a fish net-like pattern. This is a photo-livido pattern, which means this patient has been on the drug for months, and it's when they go out in sunlight, they develop this net-like pattern. There's only one drug that does this. This is quinidine will do this. Quinidine, which is used for heart rhythm. This is a pathognomonic quinidine eruption. So I'm just giving you examples here of how the pattern of the drug, what we can do for you when you call your friendly neighborhood dermatologist, or what you can do yourself if you have the knowledge to look at a patient who has an eruption by the pattern of the eruption, by the time course, what the patient's on, to determine which drug. This is what we call fixed drug eruption. Fixed drug eruption, they're round to oval in shape and very characteristically have a dark center, a pigmented center. And there's certain drugs that give fixed drug eruption. Fixed drug eruptions you see with phenolphthalein. That's the most common. What's phenolphthalein? Phenolphthalein is what's in Phenamints and X-Lax. A lot of your patients, it's not being prescribed by the physician. When you ask them what drugs they're on, they won't even list those. But when they get these recurrent fixed drug eruptions, that's by far the most common. So phenolphthalein, it's in Phenamints, it's in X-Lax, it's in rosé wine, it's in some processed foods, and will give this very characteristic eruption, and these can be blistering reactions. Very common location is head of the penis or on the vulva in a female. And they're convinced they have herpes. They're convinced they have VD. And basically every time they become constipated and take their X-Lax, their penis blisters again in response to the X-Lax. And once you identify the agent, it's very easy to eliminate. Again, fixed drug eruption, red around the periphery, dark in the center. Very characteristic. Other drugs that do that, prescription drugs, phenobarb. All of the barbiturates can do it, but phenobarb by far the most common to give a fixed drug eruption. Tetracyclines, sulfa, and salicylates, aspirin type drugs. Again, fixed drug. I'll just show you a few pictures. This is the fixed drug on the penis. This unfortunate gentleman, every time he takes X-Lax, this happens. Unpleasant for him, and frequently the problem is not so much the discomfort, which they could live with, but they've just been to their family doctor who told them he thought it was herpes. They've been happily married now for years. How can they have herpes? There's a lot of baggage that goes along with that kind of a diagnosis. This is a blistering fixed drug. When you see a blistering fixed drug that's not on the penis, that's elsewhere, it's almost always sulfa. So you've narrowed it down almost to one agent. Blistering fixed drug somewhere other than on the penis, sulfa drug. Why do we need to make the diagnosis? What's the significance to your patient? Well, one, the discomfort, needing to eliminate the drug. Number two, second question, most of these patients who are on drugs, no one gets put on a drug with no reason. There's always an indication why they're on the drug. When you say, well, this is a drug eruption, you're not done. Second question, which drug? I've tried to help you with that one. Next question, do we have to stop the drug? And if we have to stop the drug, what can we substitute? Those are the important questions to answer. In this case, this is Coumadin necrosis. This is a patient who's developed a DVT, deep vein thrombosis, and to help prevent pulmonary embolism, clot being thrown to the lung, they're put on Coumadin, anticoagulant. They develop over the fatty areas of the thigh, the breast, they develop these widespread areas of necrosis. Looks horrible. Patient's family is not happy. Patient is not happy. They're panicking. Question is, what do you do? If it's Coumadin necrosis, you do not have to stop the drug. You continue to treat through. Your stopping the drug will have no effect on the course of the Coumadin necrosis. This eruption is definitely due to the Coumadin. The patient already knew that. You do not stop the Coumadin. You treat through. Now, if this were heparin necrosis, which looks very similar, heparin necrosis, you must stop the drug because they at the same time are developing an autoimmune thrombocytopenia. Their platelets are going to nothing. So heparin you must stop. Coumadin we generally do not stop. So knowing which drug, knowing do you stop it, do you not stop it?
What if they're on both?
You look at their platelets first, because if it's heparin necrosis, they're usually dropping their platelets. Also, the time course, it's usually not during the immediate switchover period to Coumadin when they've been first heparinized and then on Coumadin. Heparin necrosis is normally seen not with intravenous heparin, but with chronic subcutaneous heparin in debilitated patients. So you will have plenty of opportunity in the geriatric population to see heparin necrosis. I mean, how many of those patients are on sub-Q heparin? Quite a few. And that's your patient population to develop heparin necrosis. So they're usually on heparin as a single agent. Coumadin necrosis is a window time period where before your clotting factors disappear, your protein C, which is an anticoagulant that's also vitamin K dependent, that dips first. And there's a little window of days after you've been started on your Coumadin where Coumadin necrosis tends to occur. So the time course and the setting of the patient it's usually not a question which of the two it is. And you look at the platelets in heparin necrosis, if you're looking, you'll see that the platelets are going down. This patient has been placed on a sulfa drug and is developing what we call atypical target lesions. These are not the typical bullseye-like target lesions of erythema multiforme. These are atypical targets. Some of them have a dusky center. They look superficially necrotic. Some are becoming blistering. This one, get them off the drug, get them off fast. Because this is what leads to toxic epidermal necrolysis, where they slough every bit of skin from their head to their feet, and they end up in the burn unit and live if they're lucky. So that's a diagnosis where you must get them off the drug. The difference between this and a true target of erythema multiforme is also very important, because there's good evidence that erythema multiforme responds well to prednisone. If you have classic erythema multiforme, prednisone is the drug of choice. You hit them early, you hit them hard, it goes away. If they have toxic epidermal necrolysis, prednisone makes them much more prone to sepsis, and the death rate on prednisone is far above the death rate without the steroids. So two somewhat similar rashes, one, prednisone's the drug of choice. The other one, prednisone can kill you. The difference is the appearance of the rash. And that difference is very important to the patients. Right now, there are big multi-center trials going on throughout the UK and continental Europe where they have pooled their resources. And it's mainly countries like France and Britain that have some degree of a socialized healthcare system and can centralize their patients into central burn units, where they can gather data and determine how best treatments for these patients. But the best data we have right now is if it's classic target lesions of erythema multiforme, the patients respond to prednisone. And it can prevent blindness, it can prevent all sorts of problems in those patients. If it's the atypical targets, bulla, superficial slough, and necrosis of toxic epidermal necrolysis, steroids will increase the mortality in some series from down around 15% to up more like 50% dying. So that's important. And that's, again, a contribution that we can make or that you can make if you have the knowledge. And this is a patient with toxic epidermal necrolysis. I won't show you the rest of the patient because it's not a pretty sight. But basically, all of their skin is detached and coming off from head to foot, leaving them open to sepsis and death. Okay, this is a little bit different. This is a contact dermatitis. Patient's been applying Mycolog. Mycolog, this is not the new Mycolog 2, but the old-fashioned Mycolog. It was a mixture of compounds, and to keep them all well mixed together, there's a substance called ethylene diamine, which was put in. And the ethylene diamine was to stabilize the whole mixture so it didn't separate out. Ethylene diamine allergy by itself doesn't mean a whole lot to the patient. Even if we come and see your patient and test the patient and say, oh yeah, he's ethylene diamine allergic, patient says thank you very much, wasn't very worth a whole lot to them. But if you tell the clinicians and the patient you're allergic to ethylene diamine, and these are other things that now you already know you're going to break out from. This patient has COPD, is chronically on theophylline. What if he decompensates and comes into the hospital? There's a good chance that he'll be given aminophylline by vein. What is aminophylline? Aminophylline is theophylline stabilized to make it soluble with ethylene diamine. So patients who have their little rash from their ethylene diamine, you already know that if you give them IV aminophylline, they're going to have that rash from head to foot. So you do them good by warning them in advance of the cross reactions. And I've given you a list here of things that cross-react with ethylene diamine. Ethylene diamine is in old Mycolog. It is not in the new Mycolog 2 formulations. Now, interestingly, Mycolog 2 came out. Every company that made a generic Mycolog changed their name, putting a Roman numeral 2 after it. It wasn't any different from their old Mycolog. It still had ethylene diamine, but it had a 2 after it. And we saw instances where patients would go to the pharmacy with a prescription for Mycolog 2, would have a generic substituted, but the generic was not the nystatin and triamcinolone of Mycolog 2. It was an old-fashioned Mycolog that happened to have a 2 after the generic name. There was much unhappiness and gnashing of teeth about this, and to my knowledge, there is currently no generic on the market with a 2 after it that is not now an equivalent to the modern Mycolog 2. And that is safe and has no ethylene diamine in it. Atarax. Atarax is an ataractic sometimes used by the psychiatrists, much more commonly used by us as an antihistamine, often used for sleep as well, especially in older patients where you don't want to heap on the benzodiazepines and other drugs necessarily. Sometimes a little Benadryl, a little Atarax is just what they need at bedtime. But Atarax and Vistaril are classified, you know, when you look at your antihistamine classifications, there are alkylamines and there are other groups of antihistamines, and there are groups that basically are ethylene diamines in their chemical structure. Atarax, Vistaril, pyrobenzamine have a structure that's an ethylene diamine-like structure. Anyone who has had their little contact dermatitis rash to ethylene diamine, if they're put on Atarax, Vistaril, pyrobenzamine, again, they will look like this from head to toe. Zinc pyrithione, Head and Shoulders. Head and Shoulders cross-reacts with ethylene diamine. So your patient has dandruff, Selsun Blue is fine, Head and Shoulders not so great if they're ethylene diamine allergic. And all of those things are well worked out cross-reactions. They can be, we know them in advance. We can warn the patient in advance. That's why it's sometimes worth calling us in to do the allergy testing. Patient was applying a cream, got a contact dermatitis to the cream. You and they and everyone else know that the cream gave them the contact dermatitis, but does it mean something else? Is it a warning about cross-reactions for a future drug? And that's where sometimes the allergy testing is worthwhile. And interestingly enough, of patients who think they know what caused their allergic eruption, they're only right 50% of the time. 50% of the time they are dead wrong. So it is worthwhile doing the allergy testing. Paraphenyldiamine. This patient she likes to dye her hair periodically. She uses a paraphenyldiamine hair dye. When they react, they will not react on the scalp. Where they'll react is the eyelids and the ears. That's where they'll react to paraphenyldiamine. Paraphenyldiamine cross-reacts with a lot of the other, paraphenyldiamine is your jet black hair dye, but it cross-reacts with a lot of the semi-permanent hair dyes in various colors that are used as well. So any hair dye reaction, and it's typically not on the scalp, but eyelids and around the ears, it's worthwhile testing them for allergy to paraphenyldiamine. Why? Again, drugs that you already know will give them a rash head to foot if they're allergic to paraphenyldiamine. Sulfa drugs, thiazide diuretics, benzocaine, procaine, procainamide, sulfonylureas, which are your oral diabetic drugs again. Paraminosalicylic acid, which is not used much anymore. That was a tuberculous drug. But there's now a new fenformin derivative, which is back on the market now as an oral hypoglycemic. DBI was the old, remember DBI was the first oral drug you could take for diabetes. Okay, this is the quiz. My pharmacy friends. Now, you're maybe a little young to remember this, but either one of you know what DBI stood for? Why the drug was called DBI? It was very simple. It was don't buy insulin. DBI. So DBI was the pharmacy company's name for the first drug, the oral drug you could take instead of insulin. But it had lots of side effects. It's off the market. But there's a cousin to it that just came on the market this last year. That drug is perfectly safe as an oral diabetic agent in patients who are paraphenyldiamine allergic. So you got a whole class of oral diabetes drugs that you can't use in those, and one that you can use. And you already know in advance, based on your allergy testing to the patient who had a hair dye reaction. So you've done them some good. And this is just a close-up of her face and the, again, weeping eczematous reaction. Now, how are you going to treat this one? This one's on the face. Triamcinolone, a little bit too strong. But hydrocortisone or tridecylan, decinide, are good agents for on the face. And if she has some around her eye, and remember this typically does affect the eyelids, tridecylan ointment, if it gets in the eye, will not do her any harm. So she doesn't have to worry about how carefully she needs to apply it. This one, weeping from the ear canal, down from the ear. This is allergy to cortisporin otic. And you see them so commonly. And what happens is this patient gets a little otitis externa, a little swimmer's ear, goes to his family doc, ER doc, excuse me, whoever, gets cortisporin otic suspension, reacts to the cortisporin otic suspension. And there are a number of things that they can react to there. Thimerosal, a preservative, is one. They can react to neomycin, but they get a rip-roaring reaction. They start to ooze out of that ear. Looks pretty bad. They go to the emergency room. People in the emergency room look in their ears, say, wow, you got a horrible, horrible external otitis. You better take this cortisporin otic suspension home and start putting it in that ear. The ear gets worse. Well, you've been using it, what, twice a day? Well, let's go with every 2-3 hours. I mean, you see that very, very commonly. And simple allergy testing, we can say what was the culprit, what's an alternative. Now, for you, for practical purposes, things that are an alternative, Domburrow Otic is a good alternative for these patients. Now, Domburrow Otic, it is not a soothing medication. It burns a little bit when it goes in. They may need to use a topical steroid or even oral steroid, oral prednisone, in addition to the Domburrow Otic in the ear. But Domburrow Otic is safe. And as long as the ear drug is not perforated, Cressolate, which is an old otic preparation, is fine to use. It's not to be used if the eardrum is perforated, but if the eardrum's intact, Cressolate's good. Our problem is most of the time their ear canal is so swollen you can't get a look in there to see if the drum is intact or not, and you're better off going with your Domburrow Otic. So Domburrow Otic is our standby, together with a topical steroid or oral steroid when it's needed. Okay, one more. This is a nice older man. He's not very happy with his life. He's an alcoholic. He wants to make some changes. He's come in for help. He also mentions that his slippers just drive him crazy. The athlete's foot he has itches like nothing he's ever had. Pattern of the athlete's foot is a little funny. It's all across the top of his feet. It's not athlete's foot. That is an allergy to the elastic in his slippers. You test him and you find out he's thiram allergic. Thiram is a rubber chemical. It's used in vulcanization. Basically, rubber from a rubber tree isn't worth much. It's too fragile. It breaks, it's brittle, so you can't do much with it. You have to vulcanize it. If you let it vulcanize, when you mix sulfur with it and let it vulcanize, you can go broke by the time you produce any usable rubber. So they add chemicals. And they add chemicals to speed up that vulcanization process and then to shut it down when they're at the point they want. And then they put in antioxidants to keep the rubber from breaking down. No one wants a tennis ball that cracks and goes to mush a week after you bought it. So they put all these chemicals in. Well, the rubber itself doesn't cause that many allergies. It's all the chemicals that they've put into the rubber that causes the allergies. Rubber allergies have been known for years and years and years. And most of the reputable companies that made rubber products had gotten rid of a lot of those allergens. Then came the AIDS epidemic. And all of a sudden, you couldn't buy Travenol gloves. They were out. You couldn't get them from the warehouse. There were suddenly little companies springing up in Singapore and everywhere else making rubber because they were close to the sources of the rubber. They could produce lots of rubber, and there was a market like crazy for rubber products all of a sudden. Condoms, gloves, anything you made out of rubber would sell. Well, these people, there are only that many experienced rubber chemists around. So who are you going to employ? Buy a chemist. Get people in. What do? They go to the textbooks. You want a good, quick, easy, cheap, strong rubber product. Bring on those old formulas. All the old accelerators are back. We've been seeing rubber allergy like we hadn't seen for 30 years before that, has been back since the AIDS epidemic. So this is very common, and you'll see it extremely commonly now. So this man is thiaram allergic. Why is that important? Well, if he goes on antabuse, what is antabuse? Antabuse is tetraethyl thiaram. How was antabuse discovered? Antabuse was discovered in Akron, Ohio. Akron was the rubber capital of, that's where Firestone was, that's where all your tires were manufactured in Akron. The entire population of the city of Akron would spend the entire weekend vomiting. Why? Because they would work all week. On the weekend, they'd want a beer, but they'd be absorbing thiarams through their skin all week. And on the weekend, when they would have their beer, they would have the most horrible, violent eruption or reaction with nausea and vomiting. When they worked out what the chemical was, they used the actual chemical that was used in the rubber industry is what was developed into antabuse. So antabuse is a rubber chemical that is safe for injection and is used to induce that same kind of reaction that the rubber workers used to get. Well, if you're allergic to the thiaram, God help you if someone injects you now with a thiaram, you're going to be in big trouble. So these things are worth knowing. These are becoming more and more common, these reactions, and you need to know something about the cross reactions. So when you see a contact dermatitis or drug eruption, how can we be of help to you? We can help you by saying which drug by the time course and by the pattern, by saying does the drug have to be stopped or do you continue treating on through the eruption? If the drug is stopped, what can we substitute? What's safe? And does this reaction warn us about any future reactions this patient may have to things? We're going to run through just a couple more patterns. This is a lichenoid eruption, very typically seen with thiazide diuretics and with gold. This is a typical gold eruption. Lasix blisters. And these can become generalized. I mean, they can slough their skin all over the place with these. Very characteristic for Lasix. So these are specific drugs that give specific types of eruptions. Amiodarone, which is a heart rhythm drug, gives this very characteristic skin pigmentation. It's harmless. Patients don't really like it, but the pigment itself is not going to harm the patient. This patient is getting chemotherapy. The question from the oncologist is, look what's happening to the guy. Do we have to stop the chemotherapy? Well, his chemotherapy includes 5-fluorouracil. These are all just actinic keratoses, the little precancerous sunspots that are dying as a result of his chemotherapy. It's safe. No harm to the patient. Continue treating. Not only may you cure his cancer, but his face is going to look great after this heals. A little more severe, but the same reaction. This is just a 5-fluorouracil reaction in the precancerous sunspots on the person's face. You do not have to stop the drug. In fact, you're doing the patient a service. There's no harm from this. Looks scary, but there's no harm. One last. This patient brought into me, actually we were consulted, he was on medicine service. This was, in the last 2 years, this was his 20th episode of cellulitis. 20th admission for cellulitis. I'll cut to the chase scene. I mean, the little history we were able to elicit is this guy was very concerned. He didn't want to get these reactions, so every time he would get any kind of a cut or bruise, he'd put a little tincture of methylate on there. Make sure, he had his little bottle of antiseptic and he'd put that tincture of methylate. He was reacting to the ethylene diamine in the tincture of methylate. He'd get a contact dermatitis, secondarily infected, staph, cellulitis again. And it was as a result of his attempts to doctor himself and prevent the problems he was having, he was perpetuating it. So another case where we can sometimes, by the pattern of the eruption, we can do some good, and we can also tell him, ethylene diamine, avoid the aminophylline, Mycolog, Atarax, Vistaril, Parabenzamine, Head and Shoulders shampoo. So this is sort of a twofer. We get 2 for 1. Not only will we prevent you from getting cellulitis the next time, but we'll give you a little extra benefit on top of that. And I will leave you one guaranteed to make your stomach turn and your toes curl. This is what we call iododerma or halogenoderma. The first couple of patients I'll see you are being prepped for thyroid surgery to show you the characteristic pustular eruptions that they can get. And these are actually very common. And the question we get with the younger patients, and sometimes older patients who need thyroid surgery, they're being prepped with the iodine. Now they've got these pustules, and the surgeons are saying, hold on, do we cancel the case? What's going on? It's not infectious. They can go on with their surgery. Halogens are seen in lots of other things. It used to be in bromous ulcer. Nowadays, we see it most commonly in older patients who are being treated for periodontal disease with high-dose repeated fluoride treatments. And I'm going to show you the picture of a gentleman, nursing home patient, being treated by very well-meaning people who wanted to treat his periodontal disease. But this was the unrecognized consequence of his fluoride treatments for his periodontal disease was really a nasty halogenoderma, and he was being biopsied to look, was this tumor, was this cancer, what was going on with this guy, was it infection? It was his fluoride treatments. And very characteristic eruption. And if you look microscopically, the eruption is also very, very classic, very typical. So you can get the diagnosis and do a lot of good for the person. Okay. Did not mean to ruin your lunch.
How long was it before you broke out in those times?
Typically, they have been on the fluoride treatments already for a number of months at that point.
And what formulation of fluoride is it? Is it like Stannis? Is it like...
They use, they're usually Stannis fluoride preparations, similar to the rinses that, like the FAAD rinse. And the gels, I mean, they have that grape flavored gel that they use for the kids. Any of those, when used simply for the teeth, are used once a day. But talk to the periodontist about how they use fluoride in these intensive treatments where it becomes antibacterial, where they're using it for periodontal disease, and it's very effective for the periodontal disease. And it's supposed to be swish and spit.
Right. And so they are swallowing this?
They are ingesting various amounts. And the amount that they ingest does not have to be, they don't have to be swigging the bottle, and you don't necessarily are accounting for the missing bottles on the shelf with these patients. They're not necessarily ingesting large amounts, but people who don't have a great gag reflex are often ingesting enough of this that we are seeing halogenodermas. They'll present on the face like that. They'll also present on the legs as these horrible pustular, oozing sores all over the legs. And it's just a result of the fluoride treatments. Used to see it. That's why bromous ulcer no longer has bromine in it, by the way. Okay, so that was a little waltz through the wonderful world of drug eruptions. Any questions as to diagnosis, therapy? What I hope I helped you with is the fact that we can sometimes do you some good with these patients, and not only in guidance of is it a drug eruption, because you already know that, but there's a lot of other information to be garnered. Any questions, or was it clear as mud?
You just mentioned
Paraphenyldiamine.
has a first reaction with cane. What about lidocaine?
Lidocaine is fine. Yeah, the amides are fine. It's the ester group that they cross-react with. So benzocaine, procaine, those are bad. Nuprocanol hemorrhoidal ointment is fine, because that's an amide. Lidocaine is fine. So the amide group are fine. Pramoxine, which is what's in Proctofoam, that's fine. Okay, doesn't cross-react. So of the topical anesthetics, there are certain ones that they can't use and certain ones that they can use. And very easy to give the guidance as to what will get them into trouble down the road and what won't. And you can prevent a lot of disability and a lot of unhappiness.
Yeah, if I could just go back to that.
Okay.
Thing for 1 minute.
Oh, that one really got you, didn't it?
Yeah, it really did. Okay, on the treatment, obviously you would discontinue the fluoride.
Yes.
But
Down the road, what are you going to do? Oh, as far as the local treatment, usually there is not any secondary infection. The eruption will resolve after the halogen is discontinued, and that is the treatment. That's it. That's your intervention.
end up looking just like you did before.
When they, not entirely, but you will be amazed how good these people look. Scar can't be reversed, but most of this is not scar. Most of this is heaped up what we call pseudoepitheliomatous hyperplasia, which is almost a cancer-like growth of the epithelium. And it's just pocked with pus. I mean, at all levels, if you cut through this, it's just pus everywhere through it. When all that resolves, there's so much epithelium there that there usually isn't that much scarring, and the whole thing goes down, and they look remarkable. That's a good picture. It usually gets a reaction. And you had,
Just about before the trial, I was wondering if they're going to approve an infection across necrosis that's higher dose than the typical replacements, like 50 milligrams.
we're waiting in the wings like vultures, waiting to see what will happen. A lot of these, what we'll need to find in the future is what are the thresholds? What's safe, what's not safe? You know, first comes safety and efficacy, then comes dosing, and then come all the little niceties down the road. It's a drug that obviously is going to do a lot of people a lot of good, so it's hoped. Although the studies, my understanding is the studies for osteoporosis and fluoride have been mixed, but it's a hopeful agent, and how it's best used to avoid problems will come with time. I have no doubt that as these things, you know, it was gone with Bromus ulcer, and we thought we'd never see it again except in the pre-op thyroid patients, and now it's back with periodontal disease. As different treatments become available, we see their side effects, and then there's time for fine-tuning after that.
I was also going to ask, among the seizure drugs, how cross-reactive is dilanthapine and tegretol?
There is some cross-reaction among those three. The one, Depakine, is the one that tends not to cross-react with the others. So that one you do better with than those others. Tegretol, dilantin are probably the highest incidence of liver problem with one, get liver problem with the other. Depakine's usually okay, and the problem with phenobarb is usually if they're at that point, phenobarb's not really a great choice for long-term management anyway for most of those people, so they're looking for some other kind of drug. Anything else? Okay, I hope next time you see one, you'll call us.
Not going to look like that. You told me I didn't need to do anything.